When we started out here in 1985, I created what we call a biorepository. That means we collect blood on virtually all patients at the time of transplant and then on a protocol for life. This is done also parallel with obtaining liver biopsies on these patients and collecting a huge amount of data on every patient, every drug they take, every rejection they have, every reoperation they have, every complication, and all the relevant chemistries that we collect. The database was known from the beginning around the world. However, this biorepository, this collection of samples, blood samples, was unknown until 2009 when we celebrated our 25th anniversary. At that time, I announced the existence of this collection, which is now like some more than 35,000 samples. And since we have all the clinical data, everything that happened to that patient, that is, all that happened to that blood sample we have, we can really dissect out what in the blood can be relevant and important to tell us what's going on and maybe find out before something happens and how we can treat it more effectively. We have already found that there's antibodies that are created either before the transplant or after the transplant, and some of these antibodies may be very important for the long-term outcome of that liver transplant and the patient. The biorepository is kept in a single place. It's sort of organized with the help of a very advanced computer system that let us know exactly where each and every one of these 35,000 specimens are. So we know when we're looking for a particular specimen in a particular patient with a particular problem and a particular history, we can pull those specimens out and analyze them. We have engaged some of the leading investigators in the world to work with us. And what we do is that investigator have an idea, a thought about something, and he has a technique to analyze the sample. And he comes and approaches us and asks us what we want to do, if we want to do a study with him. And then what we do is we scan our database and find out the patients we have, if they are appropriate, etc. We pull out these samples and send a piece of that sample. We're talking about sort of very small amounts because we are very, very cautious how we use these samples because they're irreplaceable. And then we send them out. These are frozen very, very cold, minus 70 degrees centigrade. And the investigator, say for example at Emory or at Scripps, do the study, do the evaluation with this technique that he or she has. They send us back the results, and we spin our computers, the database with our statisticians, and find out how that particular finding relates statistically to the clinical finding, essentially to prove or disprove the hypothesis that that investigator together with us have raised. How can we treat patients in the future better, with better outcomes and less complications? How can we make it more relevant what's in the blood and allow us to act before something happens? In addition, we do a number of other studies on our patients, trying to figure out what affects their kidney function, how to treat them after transplantation, how to monitor the regrowth of livers that we take a part of from a relative and give to a patient. How we can monitor that in a more exact scientific manner than we have done up to date. We're always active, we're always working, and I would say we're always writing new textbooks. The next textbook that is the mantra of liver transplantation worldwide will come out in its third edition this May. And Dr. Busatil at UCLA and myself are the editors of this textbook. The name of the textbook is Transplantation of the Liver. It's used worldwide by anyone involved in transplantation. Coordinators, nurses, and of course surgeons in training, as well as attending surgeons. And physicians, hepatologists, you name it, everybody is using it. Without this clinical research, treatment will never be improved upon. Treatments are not designed solely in a lab by hypotheses and applied. Many of those ideas turns out not to work. We have to try everything that we have, every single piece we have in patients. And clearly the patients are unsung heroes. They have to take the risk of that this drug or new treatment scheme we have may not work. But without these volunteers, we would never be where we are today. And we will never be any further in the future if we don't have these patients get into these trials. So without these advances, these investigators and their willing participants, the patients, we will go nowhere, not just in medicine, but in any field.